McGill University. He's been practicing palliative care medicine for over 20 years in both Europe and Canada. In 2005, he received both the CIHR New Investigator and Fonds de la Recherche en Santé Chercheur Boursier Clinicien Career Awards. Through a Canadian Foundation for Innovation Award, he founded the McGill Nutrition and Performance Lab. His research and clinical activities at this lab were developed in partnership with many people, including at Concordia University with Dr. Kilborg for the Department of Exercise Science, as well as the lymphedema program of Dr. Anna Towers, as well as the Division of Geriatric Medicine with Dr. Moret. I will say that he's one of the most curious, brilliant, and innovative researchers that I know, with many research interests, including cachexia and sarcopenia. He's first and senior author for over 50 publications in peer-reviewed journals, and his most recent research interests includes the use of therapeutic cannabis for relieving cancer pain and cancer-associated symptoms such as anorexia, weight loss, and also validation of tools for assessing nutrition and performance in advanced cancer patients. So I think this will be very interesting to finish with for today. And thank you very much for coming today.
Perfect, very good. Do I need to use like this microphone? Perfect, very good. Good afternoon. I hope that you had a nice coffee. And I'm just coming out from our clinic, and the first recipe for success is teamwork. So as you can see, I have two valid co-workers, colleagues that have sort of also helped me to put together this review, and I hope you find it interesting. I like a lot the discussion at the end, so I will try to skip through quite quickly the slides. If you have questions, please raise your hand. And I want also to say that it will be like in your folder or or downloadable, whatever. So don't rush to take too many notes. Okay, so these are the objectives that were suggested, which in fact are pretty much relevant to my expertise, and. We kind of will try to cover them. Possibly we'll spend a bit more time on the one that perhaps are a bit more up to date, like a number 4 item. So I don't have any specific commercial interest, except that I collaborate with companies who are trying to develop more tools for cancer patients, to help cancer patients, but I don't sell cannabis, and cachexia doesn't have really any medication to propose yet. So, my consultation has been really on the scientific perspective and all the research. So these are, I don't think I have any bias to mitigate. So the first thing that I would like to do with you this afternoon is try to really identify what means exercise and nutrition in patients, in oncology patients. And the first question, obviously, if I have cancer, should I exercise? I guess after the presentation of Dr. Béliveau, there is no doubt that, if you have a survivor, for instance, you should really exercise to prevent recurrence of cancer. But we'll see how important it is also in terms of quality of life for these patients, and particularly for fatigue, for example, or helping patients will maintain their role, their social role, their what we call the functional quality of life. And so in this intervention, to be honest, I never saw any paper say that exercise was contraindicated, okay, as maybe other approaches. However, there is a prescription also for exercise. So far, we have been looking primarily at breast and prostate cancer, probably because those diseases are the one where you don't see a rapid evolution as other, hematological or solid malignancy, and this is certainly a gap. Whether there is a pill, exercise pill, again, we are far from there. Certainly, there are certain indications that you will read with, in your handout, but definitely there are some parameters to follow. And important is also is always supervision. I mean, it's very difficult to be able to maintain on your own these guidelines, and again, not just aerobic but also resistant exercise, and those are complementary, synergistic. They are don't replace one with the other one. Particularly in cancer patients, we are at risk of losing muscle, and when we lose muscle, we lose function, and when we lose function, our quality of life and ability to live or to continue with cancer treatments is obviously pretty much impaired. Again, we should do exercise in a rational fashion with particularly attention in deconditioned patients. At times, for instance, just today, there was the son of a patient coming to see me just without any appointment, say, my father is admitted and has progressive cancer, and what was admitted because of a obstructive pneumonia. What should we do for obstructive pneumonia in terms of number of steps? And I obviously, in those cases, what really matters is counseling, and try to understand also that as per nutrition, you don't want to overdo or over fatigue a patient that is already quite debilitated. So, it's, and I think one aspect that we need to remember, as per weight, even a stable functional level is already a success in our cancer patients. So let's not think that if things don't change, it's just a bad sign. It's probably if things don't get worse, that is, things getting worse will be certainly a negative effect. And now, these are some general indication. Again, we don't have to be too protective of our patient, but definitely avoid obvious risk. It's always important. And here are some that were listed. The bottom line, though, that we are still lacking a way to personalize exercise, and also try to then follow closely exercise prescription with the disease trajectory. And again, whether there is supervision, whether there is a schedule or no schedule, those are things that can make a big impact in outcome from exercise. Just a touch on what we are trying to do as a pilot study is to randomize to either exercise or non-exercise group of patients that are in our cancer rehab, particularly in two streams: patients receiving treatment, cancer treatment, and patients who are cachetic. We'll see what that means, and then see what means just advice versus a systematic exercise program delivered and supervised by a kinesiologist. And again, these are two projects from our master student in exercise science. So when we talk about nutrition, I guess we had a fantastic overview yesterday, but I think we need to understand that the main problem with cancer patients undergoing treatment is really losing weight. We really need to make a distinction, and I think Dr. Béliveau did. I don't know if it was perceived widely, but he says, when you are going treatments, don't think to eat only vegetables. You have to eat things that you like, protein, calories, and this is particularly important because at times we see patients that they are metastatic and they still think that just drinking juices will prevent the cancer to progress, or other things, of this type. And this is really deleterious, and it can really complicate the life of a patient, but also the family could become really frustrated about the outcomes. As you see, malnutrition is multifactorial. We have to identify the 3 different components, and in primarily our lab has been trying to tease out these 2 entities, cachexia and sarcopenia. Those are really the most important factors characterizing malnutrition, and they have one thing in common: muscle waste. And as you see, what those syndrome leads to is poor outcomes in all domains. Now, these are some guidelines again for nutrition. Certainly the first and foremost is to recognize the malnutrition and or the risk of malnutrition, and then proactively intervene to eventually counteract all the potential complication coming from malnutrition. So, just to be a bit more specific, we want to see what really means cancer rehabilitation, and we have to see that in the disease trajectory of these patients, cancer patients, and that starts really even right from the cancer diagnosis and goes either into the sort of terminal phase or in the survivorship. And Dr. Cagpo has been leading this aspect of intervention. So when we look at what is really the team that delivers cancer rehab, and as you can see, is interdisciplinary, and perhaps I still like to repeat the difference between multidisciplinary and interdisciplinary. Interdisciplinary is really a different discipline that work towards a common program, versus multidisciplinary are team members that just act and in a parallel way, which makes quite a difference in terms of the care that we can deliver. These are the main components that constitute our CarePro, and we start from the pre-rehabilitation project, and we go to actually the McGill Nutrition Performance Lab that has been the way in which we have researched all aspects related to cancer rehabilitation, cachexia, and so forth. So the pre-rehabilitation actually is quite a new entity. In fact, it's a project at the MUSC. It's actually a program that was born at the Montreal General Hospital, and the leader, internationally recognized, is Dr. Franco Carli. Dr. Julie Silver has been the physiatrist from Harvard University who worked with him in terms of developing different aspects, including the definition. And I think that when we look at the situation of cancer patients, there is nothing better than prevention. And prevention of physical or nutritional demise secondary to treatments is paramount, as you can appreciate even from not a sort of expert perspective. The problem is that there is been always little attention given to, for instance, adequate nutrition, for instance, for surgical patients. And that has been a major problem because of the level of complication, days of hospitalization, and so forth. And Dr. Carli has been showing that the results of this approach are astonishing, to the point that I was told that even Barrett, when came to see his service, at the Vigano General gave a donation to this program, you know. So so just to let you know that even politician that is very, very difficult to understand, you know, they can sort of do something good at times. Now, these are the stream that are part of the Care Pro. Again, the rehabilitation. These are what we are looking now at the Glen site, and we are then. It's a project because we still want to demonstrate an impact. So it's rehabilitation intervention with rehabilitation only for patient undergoing surgery, meaning rehabilitation happening after surgery. And we have been recruiting 15 patients. So far, we are looking at 60 patients, but it's definitely exciting to see the initial results. This is a supportive stream. So the rehabilitation that takes place while patients are receiving treatment, and this is particularly important for allowing patients to continue to receive treatment and to potentially enjoy a better quality of life, and obviously more time with their families, and obviously less time in emergency rooms or in hospital beds. We have a cachexia stream that we'll look a bit more in detail because it's a bit one of my passions. But in patients who are really suffering from weight loss and anorexia as main symptoms, it's really important to have a interdisciplinary approach, very specific, and then we'll see that a bit later. But again, the goals are the same, optimizing physical and nutritional performance, as well as quality of life and ability for patient to function. Then we have the restorative stream, which is really, I would say, the survivorship part. And we are looking at patients who have, for instance, neuropathies from treatments, who have brain fog, and essentially are cured, but are left with all these important scars. And then is where we need really to provide this patient with some help to reintegrate them in their usual lifestyles. This is something that we've been presented, and then that you will read, you know, in your slides and out. So when we talk about care of an elderly oncology patient, I think you had a wonderful presentation by Dr. Doreen Wen-Chow, and so I will not go over those aspects, but I just wanted to raise, you know, the importance of two assessment tools. One is the ESAS, or Endpoint Symptom Assessment System. This is actually a slight variation on the actual traditional one, but just to give you a sense of a tool. And then this is the Abridged Patient-Generated Subjective Global Assessment, which has the characteristic of being both a screening and a diagnostic tool for malnutrition. Particularly useful because it gives you some information about weight change, meaning how much the patient has lost, but also the rate of weight loss over time. What has been the dietary intake change and over the past 2 weeks? What has been the symptoms that have been impacting on the ability of patient to eat? And that is very, very important because that is in fact what a palliative care physician should also look at in terms of facilitating the ability of this patient to maintain a nutritional intake that will satisfy their wishes, not necessarily the requirements most of the times in the advanced cancer patient, but really their possibility of enjoying food with their families, and then change in functional capacity. And that is paramount. The performance status in this case will be a subjective evaluation of a performance status, but in general, a performance status evaluation is really, really important in this patient population, and I will give you some clarification about that. So this is a work that we did, and we sort of demonstrated that there is quite a striking correlation between the APGS score and the ESAS symptom burden. So those two assessments are quite associated, and the improvement of either quality of life or nutritional impact symptoms, for instance, may be quite associated. And this is, for instance, to give you a sense of looking at the evolution of this patient, monitoring this patient during their trajectory through our Care Pro. And as you can see, the higher the symptom, the worse is whatever quality of life or the symptom itself. And you see how we were really able to improve over time. And these, again, are patients coming from the 3 streams. And so very, very important, these tools, which can be done in 5 minutes, and then we report on tablet, iPads, they really give you the possibility of monitoring patient over time, and that should be really a must when you want to do whatever intervention in this patient population. So we also look at the potential of the APGSGA to predict survival. As you can see, does a better job than just recording weight loss, presence or absence by itself. Now, and again, the APGSGA correlates very, very well with the severity of cancer cachexia, and I think this is what I wanted to just touch upon, because again, it's one of my area of research. Cachexia is not anymore a diagnosis, presence, or absence. It's a continuum that goes into different stages from pre-cachexia to refractory cachexia. And essentially, the importance of classifying this condition is really related to the possibility of intervening as well as the potential prognostic implication. And as you can see, it's important to do a screening that will allow us, and we demonstrated that in our study, to identify these stages of cachexia, and then according to the different stages, we can then planning interventions, and which are obviously important also in terms of delivery specific services and in investing resources. And oops, I think it's blocked. Oop. Doesn't go forward anymore. So, if there are any questions, maybe we can, while we are waiting for. Oops, okay. Check the watch. So I think we are not too far from these skies these days in Montreal. Yes. Yes, I mean, I really appreciated what Dr. Beliveau said yesterday. I mean, I think but I think it has to be put in context with a patient when we are going through their disease trajectory. You know, we cannot just just take, and he pointed very eloquently that it's important to enjoy food. I mean, when we see patients that do all this kind of diet that are, I mean, that would make my stomach, upset, and they are really unable to eat because of many other conditions. I mean, it's really, really a problem. And as he was saying, it's better to treat somebody that doesn't know anything, because you can start from scratch, as compared to somebody that thinks that has, the solution, and then, you need to convince, and really you need to essentially waste a lot of precious time. I was just thinking, is any question up so far? So what has been sort of present? Absolutely, absolutely. The good thing is that we work as part of a supportive care program, which includes the palliative care day hospital, the cancer pain clinic, the the survivorship program. And so we can essentially transition patients very easily from one program to the other within the cancer rehab, but primarily between the cancer rehab and the all other services. So I think it's pretty unique in terms of model, and I think we are very lucky. We have our challenges. I mean, all these services are primarily supported by donations of soft funds, so nothing that comes from the government nor from the hospital. But I think are of an incredible impact. I mean, Dr. Towers' lymphedema is the only clinic in Quebec. The cachexia, there are probably 3 in North America. But I think, with very little resources, we've been doing quite a bit. And again, we talk about programs because we always add to the clinical service provision the training, educational component, as well as the research one. So we are very knowledgeable that unless we are able to publish what we are doing, we will not go, people will not come and learn with us, okay? So coming from this sort of theoretical classification by Ferron and Coles, by the way, Ferron passed away last year at 52, and has been quite a loss in the area of cachexia. Then we actually created a specific classification system that allows clinicians to identify patients that are in the different cachexia stages. So now we are really the tool to personalize the treatment for these patients. I can go back, but I would like to finish, and then maybe we can talk about question. So we created the cachexia clinic, and then which has a specific algorithm for interventions. Again, there are some general intervention, specific intervention. All are meant to counterbalance the pathophysiologic mechanism of cachexia. And again, for if you're more interested, you can look into our publication to see the outcomes of these treatments. So that has been our last paper in terms of the classification, operationalization of a cancer cachexia classification. So here there are some, studies, things that I would like to maybe, you can just look at. Sarcopenia. Sarcopenia is another issue. Is different from cachexia, but it's definitely an important entity, particularly in elderly patients. And before, sarcopenia was just meant to be a loss of muscle mass. Now we know that it is also loss of muscle function. So the diagnosis is not just done on the basis of volume of muscle, but also with the measuring muscle strength or performance. So we are lucky again because through research we can get this state-of-the-art equipment. This is a DEXA that has been traditionally used to measure bone density, and then with a software adaptation we can measure body composition. And again, that gives us the possibility of using this machine essentially in patients that are coming to our clinic. And we don't ask this patient for an informed consent because we are using this information to discuss with patients about their evolution, whether their weight gain or weight loss has been just fat or muscle or both, and that obviously has an important implication for treatment. We also use very simple equipment like the end grip dynamometry, and again, we use that primarily for measuring outcomes in terms of muscle strength, but also for the diagnosis of cachexia, of sarcopenia. And then we use a performance status tool, and again, that is the box 4 of the APGSGA, and again, that gives us the possibility of classifying sarcopenia appropriately. Okay, I guess that is the last part, and I would like then to have more discussion. We know that palliative care has specific, palliative and supportive care has specific aims that you can see, and but we know that at times we can't really complete the job unless we integrate palliative care with new approaches. And what we are looking right now is really to what can be achieved with cannabinoid-based medication. And obviously for me it was a natural, being so interested in anorexia and weight loss. I mean, we don't have anything that works as good as cannabis for appetite. There is no doubt, except that the research is still, the clinical research is still trying to satisfy, the criteria of evidence-based medicine. Now, obviously, there is a lot of debate, and the lack of randomized clinical trial is still affecting the choice of physician to embark in this domain. However, this has been quite a long history for cannabis and for different diseases, and but it's been, at a kind of rocky trajectory because it's been, cannabis has been criminalized, and I think for good reason in terms of recreational use, but that has impacted also in the access for medical use. However, we have been sort of dispensaries around the world. The problem with dispensary has been the quality of the cannabis that is provided, because it's always like, you never know what you're getting, and patients say, yeah, sometimes it's good, sometimes it doesn't work. So a very, very sort of imprecise approach. There's been some legalization, particularly starting from the US, and now in Canada is legalized for medical purposes. In 1 year, it will be legalized for also recreational use, and that is a problem. Now, I think just to talk about cannabis will take probably a couple of hours, but I just wanted to give you some sort of indication what could be the topic for conversation with your patient. First of all, the difference between THC and CBD, okay? But also the idea that cannabis is really an entourage effect, meaning that there are so many active molecules which could be the molecule that gives the flavor of the cannabis, the smell of the cannabis, and those are really the ones that at times achieve the therapeutic effect. But for Health Canada regulation, each product has to be labeled according to the quantity of THC and CBD. And yes, the THC they acts on different receptors. We know primarily the CB1 receptor, which are localized in the central nervous system, and that is where effectively their action takes place. The sort of central nervous system structure that you see are really the most archaic part of our brain. That means the one that will determine the emotional participation to the suffering experience. And many patients will tell me, doctor, I still have the pain, but I can cope with it much better. Okay, and that is really where the cannabis works. I call it as a depersonalization of suffering, and that is absolutely important for chronic conditions and all sorts of pathologies. One thing that I wanted to mention, though, that we are still understanding the role of CB2, and particularly with CBD in terms of chronic autoimmune diseases. So there is still a lot to learn in that, and we still don't know how the CBD really ingredient works. Again, just to show that, when you think at marijuana or cannabis, we don't talk about marijuana because it's a sort of a negative term. It's like narcotics instead of opioids. Cannabis is really primarily known for the effect of THC, but the effect of CBD is absolutely critical in many conditions, particularly anxiety, inflammation, and also protection from the side effect of THC. The good thing of CBD is that it's absolutely not psychoactive. So when you are looking at products which are CBD only, essentially those are very, very safe products to take. They don't impair cognitive functioning, memory, concentration, other things. So, and has a really big effect on certain conditions like anxiety. So there are different ways to take cannabis. What we tend to favor is the use of vaporizer as compared of a device to burn cannabis, and for different reasons. One certainly would be the more safety profile in terms of using a vaporizer instead of smoking, and also the ability of having much more bioavailability of the vaporized as compared to the smoked one. In addition, when you smoke, you essentially lose 50% of your active ingredients because of combustion. With a vaporization, you don't lose that, and when you finish to vaporize, you can still use whatever is left for cooking, like edible products like cookies or muffins. We need to remember that we have some synthetic products which are now in Canada only Nabilon. Dronabinol has been discontinued. In Canada, it's still available in the States. But the Nabilon is very useful because it's a THC analog, synthetic analog, and can be used at night as a very, very important antidote for insomnia, and can be of therapeutic effect, particularly for patients that, for instance, need to travel and they cannot carry natural cannabis across a border. So And the problem with Nabilon has been that it's been always started at too high doses, so that the patient have right away had the side effects of, let's say, cannabis, and discontinued it. Okay, so we need to talk about Nabilon really started at a much smaller dose, no more than 0.25 milligram at night, to allow the body to get tolerant to this preparation. The only product available in pharmacies as a spray is nabiximol or Sativex, which is really an extract of natural cannabis, except doesn't have all those other molecules like terpenes, flavonoids, which are really very important for the therapeutic effect of cannabis. The other problem with Sativex is that the oral absorption is not that great as compared to the inhalation route. And although the effect may be quicker, and it is quicker than the oral route, but still the concentration is that you can achieve is not as good as for the other preparation. The other thing is that it costs a lot, and unless you have an insurance to cover for it, it would be impossible to do long-term treatment with nabiximols. So again, one aspect that is common to commonly misunderstood about the cannabis is the difference between the inhalation and the oral route. And for us that who are palliative physicians working with opioid preparation, we simply make a comparison of the oil format as the long-acting preparation versus the inhalation as the short-acting or breakthrough preparation. So the advantage of the oil is, for a chronic treatment, that you don't need to use it every 2 hours as you would with the inhalation, and also allows a better plasma profile to diminish side effects and improve efficacy. But obviously it's not good for the exacerbation of symptoms, and where you need something that acts much faster, which is the product that is inhaled. And again, you see the bioavailability, and it's quite variable, and again, it's towards 10% for the smoking and towards 25% for the actual vaporization. So here are a bit a panoplia of studies that have been appearing. It's obvious that although there is not a strong evidence, but there is evidence that that sort of cannabinoids are useful. This is for chemotherapy-induced nausea and vomiting, where Nabilon has been really the medication that has been studied the most. And then we have cancer-associated pain. Many studies have been conducted with the Sativex, which now has a label for cancer-associated pain, and but again with some limitation because of its poor absorption. We have, other studies now looking again at the possibility of improving symptom control and decreasing the use of opioids, which hold their side effects. Some initial evidence on the anorexia-cachexia syndrome, although the problem with this, that most of the studies have been using dronabinol, which is a synthetic compound, and doesn't really have a spectrum of natural cannabis that you can have with all those elements that will favor not only improve appetite, but also improve taste, smell, disturbances that are so common in cancer patients. Cannabis and insomnia it's incredible what you can see with cannabinoids and insomnia, nabinol being one that has been now proposed for PTSD syndrome, and but also patients that have been using multiple medication with partial effect. You just start a little bit of cannabinoids oil at night, and they start sleeping better. They start decreasing, medication for sleeping. Now, many patients in my practice outside the hospital, 7 out of 10 patients coming to a cannabis clinic will ask about, a cancer patient will ask about possibility to use it as an antineoplastic agent. A lot of evidence in the preclinical studies, but really not at this point in the sort of clinical realm. Again, we can see, a series of symptoms, and that has been benefiting, as well as the possibility of reducing prescriptions. And again, what is also interesting to see is that the side effect profile, when these products are prescribed by a physician, is really at the most mild, and definitely not impacting with function, nor determining the interruption of the treatment. Okay, so that is the other co-author of this presentation. Thank you, and I am very happy for, to discuss any of this topic.
Thank you very much, Dr. Vigano. Does anyone have questions for Dr. Vigano? You can go to the microphone. Yes. Yes, Mary?
Yes. Absolutely. So you've seen that there are, a series of interventions that we can do to address the specific pathophysiologic mechanism. For instance, one thing that we have been looking very, very, that is standard in our program is to test for bioavailable testosterone. And people overlook a lot this problem, particularly in adult patients, young adult patients. And these patients are tired, they don't sleep, they are depressed, and they are treated for all this problem. And it's very rare that somebody will say, well, let's go and test the testosterone. And we have a series of over 100 consecutive patients, 70 were hypogonadic, okay, with free testosterone. So in that case, for instance, we look at profiling all possible reversible mechanisms in cancer cachexia, being one hypogonadism, being another one inflammation. So we are very, very aggressive to try to decrease the inflammatory response. So all these patients will have a routine C-reactive protein drawn, and that will indicate us, depending on the value of C-reactive protein. If it is below 50, we normally try high-dose omega-3 fatty acid, which high content of EPA. Maybe Dr. Beliveau would have been, a great lecturer in that area as well, but we think that omega-3 are really important, and because they counterbalance the mechanism by which the body transform muscle protein in energy when there is a catabolic process going on. So when we don't take into consideration these problems, essentially we can give all the food that you like to this patient, but they will not be able to use it. And they will not be able to gain any weight and or maintain their weight. So we really need to sort of reverse those mechanisms that induce or aggravate cachexia. So all these patients go through a blood test, which include also vitamin D, vitamin B12, TSH, and the normal oncological profile. And then we assess these patients. So with this different equipment, we determine what is the degree of cachexia and or sarcopenia that they have. And at that point, we decide what is the goal for these patients, is to really restore, reverse. I mean, if the patient are pre-cachetic, obviously we can do a lot. If you are cachetic, we have to determine which are the potential mechanisms that we can reverse. And our goal is to reverse or stabilize these problems if the patient is in refractory cachexia, and that comes really with a functional demise, okay? So if a patient has lost a lot of weight but is still very functional, we can still do something. But if a patient has lost a lot of weight and is also bedridden or very sort of very poor functional status, at that point, we look more at the comfort of a patient and perhaps at a transfer to our palliative care day hospital. So that is how we use our sort of assessment. Again, most of these assessments are clinical. So we trained clinicians to recognize cachexia, sort of suspect sarcopenia, although they cannot make a diagnosis, but they can sort of suspect that there might be an issue with sarcopenia as well. And then what are the steps to do? That is essentially what we try to do. Yes. Sometimes it works, but maybe better. Yes, that's a good point. I mean, certainly what we are doing is interdisciplinary. So it's not just physician and the nurse, but it's the nutritionist, it's the occupational therapist, the physiotherapist. We are all trying to sort of determine how we can help the patient through this process. Patient at home. I think that certainly we can start identifying patients who are, severely cachetic, meaning that they lost a lot of weight and they are also bedridden. And to these patients, say, don't come to our center. You can do certain things that can help you feeling better, but don't think at your weight. So forget about your weight. Okay. So whether for patients with cachexia, we are monitoring weight, muscle strength, and other things. For patients in refractory cachexia, there is no point to give them a double whammy. Just showing that every day they lose weight, so we will tend to minimize those interventions. Now, I think that in the palliative setup, cannabinoids can be very useful. The cannabis oil is very easy to take. At small dose, you can take under the tongue and can make a big difference in terms of ability of patients to have more appetite. Now, if those patients have more appetite, but they have a gastroparesis, meaning that they feel full after they ate 2 tablespoons of food, then you need also to give them some prokinetic agents, okay? And in fact, the first steps that we normally take is to give them either domperidone or metoclopramide regularly, like 3 or 4 times a day, to help them really with this problem, particularly for patients that, for instance, have also a diabetic history. That could be a major issue. The other thing that we teach and we do is, to always check in their mouth. When they say, well, I don't have taste, well, make sure that it doesn't have a terrible oral thrush, okay? Because that can be treated and that can make a change. We also use zinc supplement, like 50 milligrams of zinc has been shown to be useful for problem that pertains to loss of zinc secondary to treatments. Okay, so we also give that, and that is a pill. It's not something that needs like a DEXA to be done. So those things can be done. I mean, when we do like an symptom inventory, like the ESAs, for palliative care purposes, we can already treat some symptoms that are impacting on nutrition, like depression, insomnia, like anxiety, nausea and vomiting, constipation. So those are the things that, that is why a physician is present in the cachexia clinic, because he can sort of look at those symptoms, look at those reversible factors. At home, I think it would be just to make sure that there are no, how many times a patient is constipated? And nobody sort of think about that, The patient starts to be nauseous, he starts to have abdominal pain, and yes, he's not eating, but as well. But, at times, just relieving constipation is a big change. So there are a lot of things that can be done, like at the level of general, approach. When you go more in the specifics, that is a bit more at the level of academic, level. You train people, you do research, you do that for, a special cohort of patients that happen to be in that center. But we cannot transport that in the houses of patients. But yeah.
Second question is around the cannabinoids. I've been looking at doing using cannabinoids for 2 years, but the inability to have control over the dosing
yes.
is like, what is this? And
yes.
I don't deliver any other drugs through the lung surface. Why the heck am I doing that?
Yes.
Especially in lung cancer patients.
Yes.
So the whole problem of being able to actually put this stuff into a capsule, there's absolutely no reason we shouldn't be able to get set dose of CBD and THC in a capsule and actually titrate it against symptoms, yes. Except that there is no
guidelines.
Well, yeah, but they can't, the pharmaceutical, like the College of Pharmacy hasn't even got how the heck you do that.
Yes. It's a very important problem. I guess all depends, again, on the lack of clinical studies. That could be a reference. Although we have more and more these studies. I've been so fortunate that I've been working at Santé Cannabis. It's the only Quebec.
I've been there.
You've been there? Good. So, and where we have a systematic approach to initiation and monitoring of cannabinoids, dose, routes, etc. I think, to give you just a very, very initial approach, you have to think at starting somebody on Nabilon, okay? I say I start patient Nabilon of 0.25. I know here RAMQ doesn't cover the 0.25, so you have to tell the patient to open the capsules, make a little solution in a bit of juice. You need some sugar to have the powder of Nabilon dissolve it and take half of that solution. That is how you make 0.25. But that is the one that allows the patient to not have immediately all those depersonalization experience where they feel stoned, they feel like high, all that kind of thing, which are really related to too much of a dose to start. So you need to induce tolerance. Now, thinking Nabilon is 10 times more potent because the affinity to the receptor is 10 times higher than the natural THC. So if you're looking at 0.25 on Nabilon, you should consider 2.5 of THC, natural THC. And that in an oil, it's easy to understand. Yes, it's in ml, meaning that you have to divide the content of THC and CBD is always expressed per milliliter. So you have to do a bit of calculation, but then you can start, 1, 2 drops or 4 drops, the 0.2 milliliter at night only. Now, and then allow again the patient to get tolerant and now to increase that twice a day, depending on the patient, elderly patient, sometimes only need one administration. And again, after that, CBD is you can use more freely because it doesn't have all those psychomimetic effects like the THC. So CBD, you can start with 5 milligram at night. And then you go to BID, and then, increase it by, 10 or 20% every week, okay? In order, again, to get slowly to the therapeutic effect. And then there are other complications. There are THC sativa, THC indica, with different, properties.
But how do you publish that kind of data? Because it's useless. Like it's like everything else out there. You just end up generating more of the same sort of mud, and like that's what I find so frustrating in the whole area. Like, sure, I would, but if you have no control and that's the way you're going to dose, you don't get anything that you can publish out of that serves any useful purpose going forward. Yes. In the last meeting I was at in Toronto, I was like, it's still not any better.
Yes. I mean, I had to tell you, there is still a lot to do in terms of education and in terms of acquiring that expertise. A similar situation is methadone, for instance, okay? So methadone, you need a special license because it's all of a kind of opioid, for pain control. In the past, like 15 years ago or 20, people didn't know what to do with morphine, they were still struggling with that. So I think it's something that will, take some time, but I think we need to remember that both the opioid and cannabinoid system are two homeostatic mechanisms in our body, and that plays an incredible role in a lot of conditions, chronic conditions. So I am hopeful, very positive. It will take some time. I certainly am concerned about the liberalization of the recreational cannabis. That will be a big problem. And that I'm not supporting that. But for the medical, absolutely.
Okay, thanks.
I just wanted to ask a quick question about the exercise. There was a slide on exercise and risk evaluation. You just went through it very quickly.
Yes.
But one of the things that came into my head was those patients with bone metastases, and what we can advise them about exercising. Like, let's say they have fairly extensive bone metastases, and a lot of our prostate cancer patients are in this situation. Now, I know those tend to be more sclerotic type bone mets, but there are a lot of them want to play golf, or they want to do whatever, or the breast cancer patients with mets that want to go swimming, or So I didn't know what recommendations you had that way.
Look, for us, the exercise that we prescribe the most in the cancer rehab is walking. Okay, so walking. There might be some contraindication, but in general, is not a dangerous activity, and it's been shown to be very useful also in patients that are much healthier. I like the swimming pool, except we have to be careful with patients that are immune suppressed. I believe that again. We probably lose more to keep this patient super protected rather than risk a little bit in terms of, exercise.
I had never seen that about swimming in our patients that are, immunosuppressed. What about the gardener who does a lot of heavy lifting?
Yes.
I'm worried about doing that kind of thing.
Yeah, that I would say that you need really supervision and prescriptions. Again, I think most of our patients want to run the marathon while they are not able to walk, okay? So that is the big counseling that we do for these patients, and we try our best to convince them. We don't have classes of, our patients that generally don't go to gym classes or other things like that. Are primarily patients who do things at home, and only for the prehab we use TheraBands, and other device also at home. But again, our patient population is really primarily patient with active disease, so where there is not a lot that they can do, in terms of these extreme sort of activities.
But if they're on bone conserving therapy, does that offer them some protection in those circumstances?
What kind of?
Like, if they're on denosumab or Zometa or some other bone conserving therapy, does that, that's supposed to diminish their risk of fractures?
Yes. Again, for this patient, just walking would be very important, okay? Yes, we know that resistance training is important, but we never give weights to these patients to do at home. We use them only for the prehab, and again, I am not a kinesiologist. The physiotherapist that works with us is primarily concerned in, I would say, more cardiovascular capacity than resistant training, really. But we don't really have a prescription very clear yet, so it's very difficult to know. And I think, when you look at this patient population, you have to do your best in terms of alerting them, warning them, but then I don't think, for instance, yes, there might be patients that have, multiple, metastases, but they like to play golf. I really don't tell them not to go, but I tell them, yes, there might be a risk of fracture, but it's up to you to decide, and most of the times we don't have, patients coming back with pathological fracture. Sometimes they just walk out of the elevator and they fracture, so it's kind of, I think you have to try to do your best and prevent the preventable, but I don't think you can immobilize somebody, and particularly if that is important for his or her quality of life.